Hello, everyone. Welcome to our podcast on clinical audit. Today, with me, as usual, is Dr. Hina Jawaid, who is Associate Professor of Family Medicine at the Health Services Academy. And we will be talking about clinical audit in primary healthcare, uh, particularly in relation to Pakistan and South Asia. Welcome, Dr. Hina.
Thank you for the invite. And it's a pleasure to be here on this family medicine podcast, which is specifically for primary care physicians. So thank you.
So let's start by introducing the topic. So to the people who do not know what clinical audit is, I think we'll start with just a brief description of or definition of clinical audit. So what is clinical audit and why is it important in primary healthcare?
Okay. Clinical audit is part of clinical governance. There are several pillars of clinical governance which regulate the quality of care that is provided. So the audit is a type of a quality improvement measure, and it's part of clinical governance. And if we look at audit, clinical audit very closely, what it does is it assesses if a certain aspect of healthcare is attaining a recognized standard. In simple words, the practice, the service delivery that is taking place, is it up to a certain mark or a standard or not? It lets the providers and patients know where their service is going and where the improvement is needed. So, not teaching our postgrads or even undergrads, we ask them to reflect on their practice and see whether they did it right. Now, that's self-reflection is a type of learning. If you broaden it at a bigger area, at a level of a healthcare facility, clinical audit actually does the same. So what you do is whatever you have practiced, for example, what medications have been prescribed for blood pressure control in somebody who is less than 55 years of age. Say this is what I want to check. So what I'll do is I'll collect the data retrospectively, or even you can do a prospective audit as well. Or you see in the last 3 months, the number of patients that attended primary healthcare facility who were under the age of 55, what type of antihypertensive agent was prescribed to them. Now, we already know the guidelines and the standards, what should be prescribed. So we compare the practice, our prescriptions with the standard guideline and see how many fall within that domain. And if somebody was not prescribed according to the guideline, what were the reasons mentioned? Any allergy, intolerance to medication, not worked previously, tried multiple different brands and stuff. So we identify the reasons. Sometimes there's a gap of knowledge. The doctor doesn't know. So the lack of awareness on the doctor's side. So the whole process and the achieved all improvements in a nutshell.
Dr. Hina, I think I lost you for briefly at the last part of your discussion. Can you repeat your last point?
Okay. Were you able to get the example of blood pressure medication that I gave? Okay,
No,
right.
yeah.
You got that. Okay. So the last bit is basically as I was comparing two things,
Mm,
clinical audit can be a type of learning. For
yeah.
instance, when we are training our postgrads about reflecting on their activities, whether they managed a patient well or not. So on a larger scale, a clinical audit is a similar thing, an institution where we are comparing our clinical practice with what the standard guideline is. And it helps us to identify areas why the standard wasn't met. Was it a lack of knowledge on the part of the prescriber or the doctor? Or was there any issue with the patient with the medication, like side effects or intolerance to medication? So the ultimate aim of clinical audit is to achieve high quality improvement and improve the clinical outcomes for the patient.
All right. Thank you very much for repeating yourself, Dr. Hina. So, is this clinical
Mhm.
audit done by someone who is within that clinic, or someone outsider comes and do this clinical audit?
Okay, clinical audit is usually done by the practitioners, the healthcare providers, the family physicians, primary care physicians themselves.
Okay.
Um, and yes, we've done it on a number of occasions. They can be part of the postgraduate training as well.
Mm-hmm.
Uh, like the, we are currently enrolling students in a one-year diploma program in our institution, and some of the students were given the task to conduct a clinical audit. We had the initial conversations, and one of the reluctancy which was coming from the students was, what if the clinical audit findings tell us something which is not going in favor of the institution? For instance,
Yeah.
medication prescribing, they're not done according to the guidelines, or inappropriate prescribing for one reason or another. So overall, they were concerned about the negative results, and that was something which I had to address. And I had to
Mm-hmm.
quote an example of a clinical audit we carried out in a primary care setting in a suburban area in Lahore. And yes, there were issues with the prescribing, but that is part of the learning, and that's what is the reason for conducting the clinical audit. That's why the audit is there in the first place, to identify the gaps. And it isn't something that should be penalized, but it should be taken as a learning. So I realized that probably we need to kind of sensitize the institutions as well, that the clinical governance has to be taken up more seriously as a learning modality
Mm-hmm.
rather than something to criticize them.
Mm-hmm.
So in future, I think I will be addressing this issue with the institutions as well. But yeah, this was one of the barriers we faced. Yeah.
So to me, I mean, it seems like more of an operational research where you identify a problem and then you go and then collect the data and then you analyze it and then you come to the final outcome, whether that is working or not working, and then you develop measures to bring improvement. Um,
Yes.
at, okay. So Dr. Hina, from what you said that you're doing it with your students also, and there were some reluctant. So can you tell me what is the current landscape of clinical audits in primary healthcare settings in Pakistan?
Okay. Clinical audit is not very regularly performed in primary care settings.
Mm-hmm.
And there could be a reason why, because not many of our primary care physicians are aware of this kind of practice of conducting clinical audits. Um, it's something that needs to be, they don't know the process either. So the reluctancy on their part is, oh, we don't know how to carry it out. They think it's something very difficult, although it's not. It's easier than research, and you can collect data very quickly as well over a period of short time. And it can be published, like we have demonstrated through one of the clinical audits, as I mentioned earlier.
Mm,
So the lack of knowledge on the part of the general practitioners, and I think as a faculty we should be taking some responsibility, because we may be the reason why they are not aware. So we need to do something about it. Like, for example, standalone workshops for private GPs within our areas, invite them for a workshop, at least tell them what the process involves and what they can do. So address the fear factor or any other questions that may be stopping them from conducting
mm,
it. And those general practitioners privately working who have got a database, a computerized setup, or they are keeping patient records, then they will be at an advantage. And
yeah.
once they start doing it, then they will realize, and they'll probably encourage other colleagues as well. And it would be nice for us to identify such practices which are doing, because then it will help us in placement of our postgrad trainees for clinical rotations in those practices, where they can familiarize themselves with the clinical audit process.
Mm.
So yeah.
Yeah, I think one of the things which I was thinking about clinical audit in Pakistan, and you're mentioning it, is that we don't have a regularized general practice. So most of our doctors who are practicing general practice, they are not properly trained, and they do not
Mm,
have the systems in their clinics to record the data and to have the
mm,
data information system. Um,
mm.
that could be one of the reasons that we don't have a clinical audit, or we have a weak clinical audit. Um, so, what other challenges do you think that health providers face in conducting a clinical audit beside, not a regular system and not having well-established GP practice?
I think lack of data
Mm-hmm.
records. There are no medical records in most practices because they still practice in the written prescription format where the prescription is given to the patient and they take it with them. And there's no record with the doctor. When we were running our medical center at University of Health Sciences, Lahore, we used to keep a record, like one copy for us and one
Mm-hmm.
copy used to go to the patient. And the copy that we used to keep, we used to file it. So the
Mm-hmm.
next time that patient would come, we would take out his file and we already have the information that this patient is diabetic or hypertensive or is allergic to a certain medication and is taking, and then we would take the next step. And
Mm-hmm.
it would also generate a record. For instance, if somebody is hypertensive on a medication, we have the record, and it gives us an idea whether we need to increase the dose of a medication or not. So not having medical record is the biggest issue that most of the private practitioners face. When it comes to medical officers within a public sector healthcare facility, mind you, there is no post for family physicians
Mm-hmm.
by the name of family physicians or general practitioners within the public sector. So they are
Mm-hmm.
called medical officers. But I think in the public sector, there's most likely a provision of record keeping. So I would
Mm-hmm.
certainly encourage those based in a dispensary BHU in RHC, make the most of your rotations, your durations, your placement, and try and get involved in that healthcare facility, how it works, know your community, and use clinical audit as one of the tools. I mean, you'll end up learning something at the end of your placement. So maybe encouraging them doing that. Yeah.
Yeah, so like you said, audits can also bring a culture of continuous improvement in the
Mm.
practice, which is very important. Um, do you have any example of successful clinical audit initiatives in Pakistan?
Okay. Right. I'll just open up the audit that was published in 2022.
Mm-hmm.
It was conducted the title was Antibiotic Prescribing Practices for Sore Throat in a
Mm-hmm.
Suburban Primary Care Clinic. Very commonly, we see medications prescribed for acute tonsillitis and pharyngitis. And the
Mm-hmm.
background was it was done in relation to the antimicrobial resistance, which has become a serious health problem in Pakistan. So it was a retrospective audit,
Mm-hmm.
which was carried out at Nansuk during a period of 1 month. Both
Okay.
adult and pediatric patients were included in it. So pediatric patients were above the age of 3. We didn't include anybody under the age of 3. And the
Okay.
reason being, we wanted to apply a criteria, which is called a CENTOR criteria for
Mm-hmm.
upper respiratory tract infections. And you can only use
Mm-hmm.
a CENTOR criteria for somebody who's 3 and above. So
Okay.
that was the reason. And we included we looked at 48 consultation cards because we have a record there and we keep the record. So we looked at the 48 consultation cards,
Mm-hmm.
which had the disease coding using International Classification of Disease 10 coding, which were labeled as either acute pharyngitis or tonsillitis. And the
Okay.
antibiotic prescribing practices were evaluated against the CENTOR criteria, the modified CENTOR criteria. So we took it as a standard.
Mm-hmm.
The criteria says a score of less than 3. So the criteria has a scoring system. So you score 1 point for each finding. So
Mm-hmm.
if the score comes out less than 3, there is no need for antibiotics in that
Mm-hmm.
individual. But if
Mm-hmm.
the score is 3 or above, then you have the provision of providing antibiotic on the same day. The score of 3, mind you, is both yes and no for antibiotic, and that is the clinician's discretion. But if it is definitely above 3, like a 4 or a 5, then yes, if you prescribe antibiotic, you are justified.
Okay.
because it says the criteria says that the higher the scoring is, the more likely there is chance of beta streptococcal sore throat infection. And it is
Oh,
proven. It's a validated score. So
right.
our results were about 28 patients, which is 58%,
Mm-hmm.
presented with modified Centaur criteria of less than 3, and they were not given antibiotics. So that was a plus sign of this audit, which means our prescribing doctors were doing something right. Sorry, I pressed on something. Which I shouldn't have. Okay.
Mm-hmm.
And antibiotics that were given on the day of presentation
Mm-hmm.
were about 20 prescriptions we identified.
Okay.
However, out of those 20, we found out that only 7, which is 35%, met the criteria for the Centaur, i.e., the patients were scoring more than 3,
Okay.
um, whereas the rest weren't. So 20 prescriptions given and only 7 qualified according to the criteria. So 13 were extra and they were not according to the criteria. So we tried and looked into the 13 and why they were issued. Is there any way we can reduce this figure to further number? Um, so that was an area for us to kind of work. We
Mm-hmm.
identified that. And the other good thing that came out of this audit was we were glad to see that most of the prescriptions, the first choice of antibiotic was an amoxicillin, which was again according to the
Okay.
guideline, the
Yeah.
WHO guide as a first line antibiotic. 71% patients were given amoxicillin, whereas 28% were given co-amoxiclav. So we did look into why they were given co-amoxiclav and if we can reduce the figure. So you can see that just one clinical
Yeah.
audit on a very
Yeah.
commonly presenting symptom,
Yeah.
giving us two different areas to look into.
Yeah.
And I think and I think the only way our primary care physicians can overcome this kind of the barrier in their mind that, oh, this is difficult, not doable. If they do it once,
Yeah.
they'll get used to it. So it's just, yeah.
Yeah, I think you're right. I'm in Australia. We have very strict. You know that you practice in England also. We have a very strict follow up for antibiotics. And if someone, and in our clinics, we normally focus on whether antibiotics are prescribed. So there is a cutoff where antibiotics should be prescribed, and if antibiotic are prescribed, then more than they should be prescribed. So there is always
Mm.
it triggers a chain of actions to
Mm.
see why are the antibiotics being more prescribed more than they are, and I think that keeps the doctors also aware of not unnecessarily prescribing antibiotics. But that's very refreshing to know that you had a very good clinical audit. And yes, I think if they're published and if the GPs are become comfortable, that practice will improve. So my next
Mm.
question is, what best practices should be followed when conducting a clinical audit, or in other words, what are the steps that should be followed when conducting a clinical audit?
Okay, so the steps for that's a very good question because it will clarify through this explanation to many of the listeners. The first step is you identify a problem you want to work on. For instance, in this case, we wanted to look at the antibiotic prescribing practices, so that was our starting point. So the beauty of general practice is you've got a wide range of topics. If you want to go into adults, medical or surgical area, pediatric medical, surgical, eye, ENT, gynae, obstetrics, dermatology. So there are plenty of avenues you can explore whichever you feel comfortable with. Emergency trauma is another one. So once you've identified a problem, you then see, do you have an existing standard, a guideline, a criteria, a recommendation
Mhm.
with which you can compare your practice with?
Mm.
Um, and yeah, so that is so defining standard is the second step.
Mhm.
Third step would be collecting.
Mhm.
So you whether you want to collect the data retrospectively or prospectively and over a period of 3 months or a month. Well, if you have a lot of influx of such patients, for example, upper respiratory is a very common thing. So
Mm-hmm.
you may want to say, oh, 1 month is enough, and I will get enough data for it, enough number of patients. So that depends on. But if it's a rare case, you may need to extend it for a previous 6 months or a next 6 months or a year. So it depends. Then you analyze your results, see the comparison. How much are you achieving the target? How
Mm.
many of the cases that you've dealt with are matching the standard? Is it 80%? Are you meeting, is your service in that area meeting 20% of the standard criteria, 80%? Depends what results you get. And that helps you identify the gaps or the areas of improvement. And then you make a change. Like in our case, we identified the areas why somebody was prescribed an antibiotic, if it was scoring less than 3 or was
Mm-hmm.
prescribed. And then the last step would be re-audit. Give the change some time, like 3 months or 6 months, implement the change, and then re-audit and see, compare your results with the first audit. So
Okay.
if the service was meeting, say, 50% of the standard in the first audit, what does the re-audit shows? Has there been an improvement of 10%, 5%, 20%? So the re-audit is another thing. Um, and if you want to get your audit published, then always seek the ethical approval from the institution.
Mm-hmm.
So then that will pave way for the publication and makes it easier for.
Okay. So it's a continuous process, right? You
Yeah.
do it and then you repeat it, and then see whether they are implemented, and then so it's a continuous cycle.
Hmm. Yeah.
All right. And do we have do we have standards for audit in Pakistan?
Okay. Standards for audit, you mean?
Yes, yes, yes. Standardized tool for audit. Yeah.
Okay. In what sense?
So in a way, like you were saying that we compare our whatever we are doing, for instance, antibiotic prescription, with some
Hmm.
standard tools that are already there. So which tools do you compare it with? Are there international standards or there
Okay.
are national standards?
So they are usually guidelines. They are international
Okay.
guidelines. For in
All right.
general practice, we use NICE, which is National Institute of Clinical Excellence guidelines,
Okay.
and they are meant for primary care, and they can be applied globally in primary care sector.
Mm-hmm.
For antibiotic prescribing for South Asia region, we use the WHO guidelines,
Okay.
which are updated every few years. So we usually have the
Mhm.
up-to-date booklet, and we compare the practices with that.
Okay.
Um, and whenever the other thing I would like to like advise GPs particularly would be, if you want to get involved in a clinical audit, in addition to setting up an audit yourself, like starting from the beginning,
Mm-hmm.
you can join an ongoing audit.
Okay.
So if you want to kind of be an observer for a clinical audit and want to observe all the steps,
Mm-hmm.
uh, you may wish to speak to your colleagues based in hospitals and say, I would like to be part of a clinical audit so I can examine all the steps and be able to do it myself.
Mm-hmm.
Um, and and whenever you're planning your audit, use the SMART criteria. So be
Uh-huh.
specific with the topics. Take small steps and an easy topic which is doable rather than for something which is too broad.
Okay.
It is something which is measurable.
Mm-hmm.
For example, it can be a national guideline. For example, tuberculosis.
Okay.
Tuberculosis, we've got very good guidelines for tuberculosis. We've got good guidelines international for contraception use. So
Yeah.
are you prescribing contraception according to a certain criteria? For example, there are certain contraceptives which we cannot prescribe if the lady is breastfeeding within the period of 6 weeks or 6 months. So we tend to be stay away from those contraceptives. And then the emergency contraceptive is another avenue where we can do an audit, because in emergency contraception there is a time limit to which up to which you can use them. So
Yeah.
if somebody wants to look at, or whether the emergency contraception was given within the time frame it's meant to be
Mm.
used, then probably that is one you wish to explore. As I said, in general practice, because we are involved in so many activities, we usually do not have issues finding a topic.
Mm.
It has to be achievable, which is the third
Yeah.
part of SMART. So specific, measurable, and achievable. Limit yourself to just one outcome or two outcome. In the beginning,
Okay.
take very small steps,
Mm-hmm.
because you need that motivation and encouragement with a positive outcome, right?
Yeah.
And a positive outcome would be, I've completed an audit, I've presented it in a conference, it had an impact on the clinical practice, or I managed to publish it.
Mm.
So achievable is something where you can collect the data easily, and you can manage it.
Yeah.
And it has to be realistic. Um, don't choose an audit topic which you don't think you may be the right person for. For example, um, a rare genetic disease.
Yeah.
Yes, they are important, but they are rare, and they involve secondary, tertiary care, and
Mm.
you may get stuck finding a case or an outcome
Mm.
or even a standard.
Yeah.
Um, and and it has to be timely, which is the last bit of the SMART criteria. It has to be timely, which means it can be done quickly and you are able to complete it. Because taking the task to completion is also like, it motivates us. It gives a feeling of, yeah, we have fulfilled the responsibility and stuff. So yeah.
Mm. Thank you very much, Dr. Hina. That was very informative. My last question, I mean, there will be
Mm.
another follow-up question, but my last question is, in addition to what you've recommended right now, what other recommendation would you give to healthcare facilities who are looking to conduct a clinical audit?
Healthcare facilities, they must have an, a clinical audit department with an
Mm-hmm.
audit lead for that department. What it will do is, because there are a lot of people who want to engage in these activities, they will be able to grab somebody who can guide them.
Okay.
So having a clinical audit department, which is under clinical governance, will be an asset for the institution and will be able to guide all the new doctors, the junior doctors, or even the experienced ones. Um, I would also suggest that those who are planning to conduct an audit, so before you plan the audit, get a taste of what all the stakeholders who can be involved in it. For example, your nurses, pharmacists,
Yeah.
physiotherapists, allied workers. Have a chat with them. It will give you an idea of what's happening currently, and what can be focused on, because
Yeah.
their feedback will be useful for you. Involve your seniors as well,
Mm-hmm.
in the different. So these are all the things that have to be done before the audit. So when you're planning your audit, you have to and that will kind of streamline and fine tune a lot of things that you will be needing in the future. And as I said, re-audit is a good thing. um, and But institutions that carry out regular activities, not only the clinical audits but monthly and mortality and morbidity meetings as well, they tend to perform better, because
Mm-hmm.
we all can make mistakes, and the purpose is not to kind of punish or penalize anybody. It is to learn and not to make the same mistake in future.
Mm.
So yeah, and it's good for the CV as well. So if you're applying for any job within the country or abroad, and it shows you've done the clinical audit, then you get the plus points about it. Yeah.
Thank you, Dr. Hina. So, what is the future of clinical audits in primary healthcare in Pakistan? How do you see the future of it? Because right now, as my understanding is, and it may be flawed, is that we don't have
Mm.
established clinical audits in clinics, and now we are coming to it. So, uh, what do you think is the future of clinical audits?
Okay, I think the word needs to go out there, particularly those institutions, like, for instance, ours is offering short courses for in clinical audit. For instance, we are planning to launch a clinical audit course, a short course for primary care physicians.
Okay.
It's divided into basic and advanced.
Mhm.
And it has online and face-to-face components and an assignment as well.
Mm.
So maybe just probably the institutions that are locally based, they need to kind of advertise this thing in the community where most of the medical officers, primary care physicians, it will generate interest among them. And they need to know that they have a facility and a course there which they can utilize and see. So it's a slow process, but if say even 2 or 3 institutions in every province do it, then the rolling effect, snowball effect will take place here.
Thank you very much. Any other final key messages that you want to give to our audiences before we conclude our podcast for today?
Okay. So the take-home message would be audit and quality improvement activities are a good way to learn more about your own field. So you need to kind of show interest and learn a new skill, and it will pay you off in future. Before anything you do, make sure there is good planning, which is essential. And once you've taken up the audit, take the task has to be taken seriously. Make sure you take it to completion. You present your results locally and nationally. There are places where you can get those published, both nationally, regionally, and internationally. So try and find out as much as you can who you can approach and what can guide you. So there's plenty of help out there. So.
Thank you very much, Dr. Hina, and thank you to the audience who will be listening to our podcast. And we have our comment section open. I would encourage our audience to share their thoughts and experiences related to clinical audit. So until we meet again, thank you very much, Dr. Hina. A very informative session, and I'm sure that everyone would have learned a lot from your experiences. Thank you.
Thank you.